Hello again. Uh, Today we are going to cover some issues together. We first start with hepatomegali. We start with hepatomegali because in most of the following diseases we are going to review, there is hepatomegali. Hepatomegali means that the liver is enlarged. And the best method to define it is physical examination. Some people would tend to think that the imaging methods like CT, ultrasonography is better, but that's not true. Physical examination is still the best method to diagnose hepatomegaly. And to measure the longitudinal diameter, we are performing percussion, starting like this, and we define the upper level of liver, then the lower level of liver, but you do not need to remember this because it is no longer used. In general, we palpate the liver like this. We order the patient to take deep breath. We start from fossa iliaca, because the liver may be too enlarged. Then when the patient is doing expiration, we go up and wait. In inspiration, we try to feel the liver. In general, the liver is not felt below arcus costarum, but slightly maybe felt like 1 centimeter. If it is significantly felt below arcus costarum in inspiration, it means that hepatomegaly is present. Renal lobe is an accessory lobe of right lobe, present in some people, and it may be confused with hepatomegaly. In practice, it does not have a significant meaning, but in most of the board examinations, it's a frequent question. They would ask that how do you differentiate between renal lobe and hepatomegaly like this? But for us now, it is not an issue. We palpate the liver and we report that whether the enlargement is minimal, barely felt, mild, moderate, or giant hepatomegaly. Giant hepatomegaly means that we can even feel the liver in fossa iliaca. These are totally arbitrary. There is no numerical points to define them. Actually, most of these have been developed before the arrival of the sophisticated imaging methods and laboratory tests. So at that time, the only mean to make a differential diagnosis was with physical examination. But now, these are not actually very significant in making a diagnosis. We report that whether the liver is soft or it is hard, whether there is pain with palpation or not, or the surface is smooth or nodular. If it is nodular, it may mean infiltrative disease is present. If in palpation there is pain, it means that there is a congestion, but it is purely non-specific. For example, in fatty liver, the infiltration of the liver with fat, in palpation, there will be pain. In general, the liver is insensitive to pain stimuli like cutting or puncturing, but the liver is sensitive to enlargement. And the liver capsule, when the liver capsule is strained, so there's a pressure on it because of increased liver volume due to any reason. I mean, it may be a cardiac insufficiency and blood congestion. There may be bile excretion derangement and bile accumulation or fat accumulation, in any type of accumulation of anything in liver because of the enlargement and the there may be pain. So in general, if there is a pain in palpation, it means that there is an increased liver volume due to some unwelcome visitor, like fat, like more blood or bile or something like this. In differential diagnosis, in the same region, I mean here, there may be MS, but not liver. For example, hydropic gallbladder. Hydropic gallbladder means that gallbladder is not emptying physiologically. That may be due to the obstruction of the cystic duct, which is draining gallbladder into the common bile duct by stone or some tumors. And hydrops, enlargement of gallbladder develops. In the same region, there is right kidney, sometimes right kidney tumors. Hydronephrosis. Hydronephrosis means that there is an obstruction to the ureter. Or polycystic disease. This is a genetic disease. There are lots of cysts in kidneys, sometimes in liver and pancreas as well. Adrenal gland tumors. And you see that there is a part of colon which is called hepatic flexura or flexura hepatica, just here. And tumors in this region may also be confused with hepatomegali in physical examination, or some mesenchymal tumors like gastrointestinal cyst prostate tumor, for example, may be confused with enlarged liver. So if you remember this to be taken into account, the differential diagnosis of hepatomegali in physical examination, that would be suffice for you. What are the etiologies of hepatomegali? So once we diagnose hepatomegali or discover hepatomegali, this is not a disease in itself, it's a physical finding. We should find the etiology. It may be due to infectious diseases like typhoid fever, brucellosis, malaria, some parasitic diseases, rare diseases, Chagas, Kala-Azar, or tuberculosis. It may be due to acute hepatitis, which is very common, sometimes in chronic hepatitis, but in cirrhosis, in the initial stages, the liver may be enlarged, hepatomegaly may be present, but in the course of the cirrhosis, the liver will go into atrophy and will contract. Hepatomegaly is present half of the patients with fatty liver. We are going to discuss it in this lecture as well. Congestive heart failure or Budd-Chiari syndrome. Budd-Chiari syndrome means obstruction of hepatic veins by thrombosis. Other etiologies, some hematological diseases like leukemia, lymphoma, agnogenic myeloid metaplasia. In addition to these malignant conditions, it may be present in some benign hematological diseases like iron deficiency anemia or B12 vitamin deficiency. Sometimes that may be due to atrophic gastritis. In some congenital metabolic diseases like Gaucher, this will be mentioned in pediatric lectures. This is an disease of accumulation of some substances in liver. Amyloidosis. Amyloid is an glycoprotein type material which is accumulated in tissues like kidney, intestine, and liver. And usually it is the result of long-standing infection, chronic infection, or chronic inflammatory diseases. But amyloidosis may be a primary type due to some genetic abnormalities as well. In our country, amyloidosis is mostly due to familial Mediterranean fever. There is an dubious disease which is called as polycystic liver. The liver is invaded by too many cysts. It's a rare disease, but a disturbing one. Hydatid cyst, which is frequent in our country, but its incidence is decreasing. It is due to Echinococcus granulosus. I think this will be mentioned in infectious disease lectures. And at the end of the list, malignancies. We told you about hepatocellular carcinoma, which develops in the patients with cirrhosis. But liver is also a very usual site for metastasis because of its rich vascularity. Most of the malignancies in any part of body will metastasize to the liver. While making a differential diagnosis of hepatomegali, we should be informed about whether pain is present, fever, night sweats, malaise, dyspepsia, presence of jaundice, or hemorrhagic tendencies. And we should be informed about whether it is acute or chronic. For example, if it is accompanied by shaking chills and very high fever, it may be due to an infectious condition. If there is pain, we have told you that there may be pain in palpation, but without palpation, if there is spontaneous pain, it may be due to congestion from heart failure. Malaise and dyspepsia is non-specific. It may be present in any type of liver disease. And the presence of symptoms, whether these are acute or they have been present for more than 2 weeks, then we call it chronic. And we ask for alcohol intake, presence of diabetes mellitus. It points towards fatty liver, or chronic inflammatory diseases that may suggest amyloidosis, like rheumatoid arthritis, familial Mediterranean fever, chronic obstructive lung disease, else. In physical examination in a patient with hepatomegali, we look for jaundice in sclera or body, presence of pulmonary erythema, the reddish discoloration of the hand, inner part of the hand, presence of gynecomastia, collaterals in abdomen. These are suggesting a chronic liver disease. If there are lymph nodes present, presence of lymph nodes in acute hepatitis would suggest infectious mononucleosis. In chronic disease, presence of lymph nodes in addition to hepatomegali would suggest any malignancy, but mostly lymphoma. Rash would suggest an infectious condition. And cardiac examination. If there are some cardiac abnormalities, that would suggest an congestive hepatomegali due to heart failure. We skip laboratory and others. So, in conclusion, for the differential diagnosis of hepatomegali, a detailed anamnesis should be taken, and the previous reports of the patient should be examined. Physical examination should be complete, and if you are in difficulty to making a diagnosis, it is better to consult an experienced physician. Now we are going on with hepatitis B. Hepatitis B is the leading cause of acute chronic hepatitis B and cirrhosis and hepatocellular carcinoma in our country. The general carrier rate is 1 to 4%, depending to the region, and around 50% of the carriers do not require treatment. So in half of the HBsAg positive subjects, there is no disease. They are simply carrying the virus, but the liver is not affected by it, and we are having a follow-up. But I am going to say that even for these patients, they are called as inactive carriers. There is a risk of activation of the disease. So when we see a patient with hepatitis B, we are having a snapshot view, but this is a dynamic process. So this time, the patient may be in inactive carrier state, but in due time, he will develop activation. So any person carrying HBsAg should be followed up. A very safe and effective vaccine is available, so its incidence is decreasing. Say 20 years ago in this country, the prevalence rate for HBsAg positivity was like 10%. Now it dropped half. And in our country, there are too many undiagnosed subjects. That's a pity because if we diagnose, we can treat effectively. But if we do not treat this patients will develop liver cirrhosis. And worldwide, there are 350 million hepatitis B carriers. So this is still a serious health problem. Treatment is aimed to stop the replication of the virus, and in case it is instituted at the right time, it prevents development of cirrhosis and hepatocellular carcinoma to a large extent. And we are going to see that cure of hepatitis B is very difficult at the present time. But we are having progress. Now,